Heather's going to be late. Whenever I see the nightly news and they say Nora O'Donnell is on assignment, I'm just going to try that. Heather Bell is on assignment. She may come in late. She's covering some kind of train derailment. She's on location. Okay, so let's get to the announcements. So we got a lot of really good echoes coming up, and I think that the next one is going to be particularly interesting on some of the criminal justice. This is actually a judge that we met as part of our talk we're giving in Atlanta. And then following that, I had a long discussion with Matt Allen, who, as you may recall, was a prescriber of buprenorphine over in Mora. And he went to New Zealand for a year off, and he's going to talk to us about how addiction care and opioids are in New Zealand. It's absolutely fascinating. So we got a lot of really good talks coming up. Remember, there's free CME. Again, if there's more than one person in your room, please let us know. And again, if you wouldn't mind putting on your video, that makes it fun for us. We do technical assistance. Again, if you have questions, we don't mind if you call us, and you can just call our cell phone. We get a couple calls a day from all over, and it's just nice that we can kind of help out. Remember, if you want to go, the manual is not quite up, but it will be soon. And you can just go to this website, and there's lots of education and resources available there as a part of Stratus in the work that we do with them. The Addiction Connection podcast just came out yesterday. Boy, it took off too. The first day there was just a ton of downloads. It's actually an interesting one on some of the odd problems with kratom. Some of the different things that we see with kratom, especially like lead toxicity and some of the interesting, less known problems with kratom. So it was kratom 2.0. So I'm doing the talk today, and so we're gonna kind of slowly move into this. This talk is, I'm just going to say right up front, sometimes suicide is a tough topic to talk about. And I think sadly, many of us have had patients who've committed suicide or family members. And so, I don't want to discount how this may kind of make some people feel. But it's really an important thing for us to understand about suicide and some of the different things. So we're going to talk about some of the different substance use disorders and how that may impact the suicide rates and the different things that we see in our practices. Next slide. And just to kind of preface all of this, actually, I had a patient about 2 years ago who, when I was doing this talk, it reminded me very much of why this is so important. I had a young man come in on a Friday afternoon who had an opioid use disorder, and unfortunately, we were unable to get him into treatment that day as hard as we tried because we could not get a Rule 25. And despite the fact that we had a bed for him, they would not accept him without a Rule 25, which we were unable to get from anybody. And 2 days later, he hung himself before coming back to our clinic on Monday. And so we always have to be thinking about how these disorders that we take care of impact patients and some of the barriers that keep us from getting them help. Unfortunately, that barrier of getting a Rule 25 has pretty much gone away now. So had this happened today, I think we could have solved that problem without it. Oh, back up one. Okay, so there's about 1 million suicides per year in the world. And really, when we think about that, in the U.S., it's almost 50,000, which is roughly about half as many as the overdoses. And I think that you have to always put that into context by the fact that about 1 in 13 attempts is generally successful. And so there are lots and lots of people who attempt suicide but don't complete it. But confirmed is about half of what we're seeing. So it's a big problem. And it's something that, again, I think most of us have dealt with at some point or another, either family or friends or in our clinics. So, and again, first we're going to talk about general suicide. We're not going to talk really about substance use and suicide quite yet. But it's interesting if you look at this list, and this list is really very typical of the risk factors for a lot of things. And if you look at psychiatric illness, having previous attempts, substance misuse, which is what we're going to talk mostly about today, stressors and relationship issues. This is really a list of the things that we see in our patients with substance use disorders also. And I think that it is very common that I'll see a patient with an opioid use disorder and they have all of these problems, especially that history of sexual abuse. And so understand that the risk factors for suicide in general are just so much what we see every single day with the patients that are coming into our clinic. I think that when we were still in school and when we were in medical school or any kind of medical training, I think one of the things that was always just pounded into our heads was how important it was to ask a person if they had a plan, because often that plan was the thing that really put them at much higher risk. I think it's interesting, and we'll talk about this a little bit later, that often, patients aren't going to talk to you about their plan. And if you look at overall, probably 70 or 80% of patients discuss none of this, deny it all, and give no warning and commit suicide. And so it's not necessarily even asking it that can be helpful, because often they will keep that to themselves. I had a patient very much like that 4 or 5 years ago, had some mild depression issues, was asked all of these questions, and then actually hung himself over the weekend before coming back. Did not discuss any of this with any of his family, his friends, and myself. And so often we're not going to have that clue. They're not going to tell you that they're thinking about it 80% of the time. Okay, so how about the prevalence? And again, we're still talking about general population. If you look at just people getting the idea that they might consider suicide, probably 1 in 7 or 8 people has had that during their lifetime. And if you look at attempts, it's about 1 in 20 people actually attempt suicide at some point in their life. And so again, I think that all of us out there and all of us on this call have clearly dealt with some of these issues, whether it's kids or family, friends, or patients. So relatively common. When we look at previous suicide attempts, I think that that's the one thing that I think I am going to take away from this talk more than anything, is that I never really thought about this as being one of the most serious parts of my discussion with the patient. Is this patient considering suicide, and have they tried to commit suicide before? Because that infers an enormous amount of risk if they've had a previous suicide attempt. And so that simple question is really what should get our radar really humming and make us think that this is a patient that we really want to make sure is safe, that we want to ask all the questions that we would consider putting in the hospital if need be, because their risk might be much more of a problem than we think. And again, compared to that general population, you're talking 50 times higher if they've had a previous attempt. So for me, it's adding that one thing to my discussion with patients as they're having problems is have you tried to commit suicide before, and how? Okay, and we'll talk about lethality here shortly. So when we look at behavioral risks, I don't think any of these would be a surprise to anybody. I think that often the patients that we're seeing in an addiction clinic or any patient in a clinic with addiction, a lot of these things are evident right away because patients come in alone. They often lack social support. And in fact, it's not uncommon that my patients say, I really don't have anybody to call. They need a ride, but they don't have any family left. They don't have anybody that will really help them out. And so it's important that we understand that a lot of times by the time they get to us, they have no social support. Often these patients may be very impulsive and pessimistic. And of course, it's those bipolar patients, those antisocial patients that also are a big risk, and substance use disorders, which of course we're going to be talking about. External factors can be a big thing for this patient group, and sexual assault is really one of the things that is the saddest part of my clinic day because I just see it so often. And if you look at the general population, patients without substance use disorders, 15% of the patients have been victims of sexual assault. And although I think we often think about, it's always women, I have sadly had quite a few men recently who have also had this particular problem. And I think it's important to understand, too, that the people that have the highest risk are really those patients who had sexual assault or these kinds of traumatic events before they were 16. This really puts them at much higher risk down the road. And so those are the patients that you're going to watch a little bit more closely. Gender differences, and this is really very interesting. If we look at just general population, men suicide victims are much more common than female. And you're going to see that there's a big difference when we start looking at the substance use disorder group. It's really much different in that particular group. And of course, there's difference in the methods, often that in the general populations, what kind of dictates what completed suicides. But in the general population without substance use disorders, men tend to be the highest risk group. So let's talk a little bit about the mental illness side of this. And we've given talks and heard talks where, people with mental illness, they get all this data about how much higher their risk of having a substance use disorder is. And it's interesting because these numbers are very similar when we look at suicide risk and mental illness. It's really the people that tend to have a lot of the depression that tend to be the highest risk. And if you look at the bipolar crowd, you look at the unipolar depression crowd, this is a group that has 6 or 7 times the risk of the general population. Interestingly, if you look at schizophrenia, and especially patients who have schizophrenia who have psychosis, they are also in that same range. And we'll talk about in a little bit about some of the patients who actually have, from substances develop psychosis. That is also puts them in that same risk category because of the psychosis. And so psychosis is clearly a suicide risk issue. Anxiety, some of the lesser issues, much less risk overall for mental illness and suicide. Now, I think it's probably as well not a surprise that when we look at what shows up in decedents' bloodstreams, it's going to be the medications that typically cause depressive symptoms. And alcohol and opiates, of course, significantly depress the mood. And we're going to talk a little bit, especially about opiates, about why that tends to really be a mood issue. If you look at any of the cannabinoids, you look at cocaine, you look at amphetamines, we're going to talk a little bit about marijuana and how interesting the data is on suicide and marijuana. I think when you look at the stimulants, you wouldn't expect to have as much of an issue with suicide, but often with some of the things such as amphetamines, where we end up with a psychosis, or with the amphetamines where some people tend to respond to them as being very aggressive. We can see them do things that maybe they normally would not do. And so again, big difference between the medications that tend to cause depressive symptoms as opposed to the ones that are more stimulating. Now, every category of substance use is actually associated with increased suicide mortality. And I think even when you look at just tobacco, and we were talking about this just the other day with students, how just tobacco itself oddly increases your risk, doubles your risk of suicide. And if you compare that to the furthest out on the other way, it's polysubstance use, which is probably around 10 or 11 times the risk with all of those substances of having a suicide. Women in general, when we look at substances and substance use, have a higher risk. And as you recall, in the general population, it's typically men. But when you're looking at patients with substance use disorders, women are much more likely to end up with a suicide attempt or a suicide completion. So a little bit about the kind of the demographics. I mean, if you look at suicide cases, it's interesting that a lot of people look to is there something else in the background that also puts them at higher risk if they have substance use? And it's interesting, this huge study, and basically what they found out is that suicide cases with matched controls, they had equal levels of finances. So really, it didn't seem to make much difference if they were having financial difficulties. Females tend to be the bigger group. And interestingly, the ones who completed the suicides tended to have more education. And I don't think that's something that, we would have just thought of. I think it's interesting that that often they're the most educated of the group are the ones that actually are completers. But if we look at women and men, and we look at the completions of suicides, often they have similar rates of substance use disorders. So it's just an interesting group, and often, especially on the female side, which is more common, often much more educated. So what are the highest risk substances? Well, alcohol and opiates, and we kind of saw those numbers from before, that those are really the ones that we worry about the most. Obviously, alcohol is so available that we're going to see that in the bloodstream of completers probably more often. And we'll talk a little bit about some of the things that seem to make it much more likely that alcohol is going to cause a problem. And of course, opiates to a certain degree, we have a lot of people on chronic pain medications, but we also have a lot of people taking these medications illicitly. And so opiates is kind of a middle group where it's relatively available, but also available on the street. So alcohol and suicide. Now, alcohol use disorder just by itself increases the risk of suicide about 5, depending on what study you look at, between 5 and 10 times the general population rate. And it's really pretty interesting that if you look at, I think my perception would be is when the patient is actually drinking and they're inebriated, that's often when they're going to attempt suicide or they're going to complete a suicide. But in reality, often what happens is it's that period after intoxication where the patient is not feeling well, they're hungover, they're dysphoric, they're around the house, maybe they're alone. It's that period which is really associated with that very high risk of suicidal behavior, 7 times higher than the general population. And so it really does make a big difference whether they're intoxicated or often in that period afterwards. But if we look at, especially in males, when we look at intoxication, it's also associated with what method patients use. And so the lethality of that attempt can be very different when they're intoxicated, especially in men where we see a much more use of handguns or firearms in those cases. I can think of a couple different times where in our town where somebody became very stressed out by a personal situation, drank an enormous amount of alcohol, and then unfortunately used a firearm to commit suicide. And so I think that's much more common in men, and men tend to use more lethal ways of committing suicide as compared to women. So if we look at people that are using alcohol and the potential for suicide, the highest risk people are actually this group. It tends to be female. They tend to generally be younger. And by younger, I would say less than 25-ish. Often these people have a very significant family history of suicidal behavior. I think I have many families that I took care of for many years who had multiple suicides in their family, and that is always something that you want to think about. I have a friend who had both grandparents and father commit suicide within years. And so those are patients that you really want to take it very seriously if you think that they're really struggling. Often the people that are drinking early in life very heavily are at much risk. And we're going to talk about that in a minute, what some of the different characteristics of their brain are in comparison to people who do not commit suicide and do not drink alcohol. Most of these patients, or a significant number of these patients, are actually already on antidepressants, but they're also drinking heavily. And so that's always something to think that, we often think that these medications are going to eliminate some of the side effects of different substances such as alcohol, but often they do not. And one really interesting thing is that the more they drink, the more attempts they are. And we're going to see this in a number of the different substances where they are dose dependent. And so greater use, more attempts. And clearly greater use also leads to probably more depressive symptoms. How about older adults? And actually, I have that one talk that I gave a while back on older adults and opioids. And often those are also people that are using alcohol. But remember that the fastest growing group of drinkers in this country that has escalated their drinking the most is the 65 and over crowd. And if you look at if you look at what's happened, they've actually had an increase of over 60% of their drinking since 2001. So that's a group that's going to be at high risk. And if you look at the 60 to 69-year-old age group, 24% of attempts are in that age group, and 13% from 70 to 79. And so age is, although we see with alcohol, the majority, or not the majority, but a high number of them are much younger people, we're still going to see it in the elderly, sometimes with loss of a spouse, loss of a job or retirement, feeling like there's nothing to live for. I think it's really interesting that if you look at this from a national standpoint, it is very clearly the more alcohol that is consumed in your country, the more suicide there is. And this is held true in especially the more developed countries where alcohol consumption is a very common thing. Some of the different countries are having enormous amounts of per capita alcohol intake. And if we look to what happened during COVID, where the alcohol intake went up by about 20 to 25%, it's pretty clear that suicide and some of these other issues also followed that. And so very linear, and understand that our country is one of the countries that there's a significant amount of per capita. But just remember that about 80% of the alcohol in this country is actually consumed by about 20% of our population. So there is one core group that is responsible for a significant amount of the alcohol that disappears in this country. So again, I talked a little bit about this in the older age group, about how at-risk drinking has gone up, and really in the last 20 years, it's really bumped up about 30%. Again, alcohol use disorder diagnosis has increased by 50%, which I think in our clinic, I think it's very interesting that probably in an addiction clinic, we're seeing probably 50% of opioid use disorder and maybe 20% of alcohol use disorder, despite the fact that alcohol use disorder is clearly much more common. And I think that people continue to drink, and often they don't really present to any clinic or any physician or provider until things are really going poorly. And so understand that there's a lot of people out there functioning, doing their jobs, and they have very significant at-risk drinking or a very clear alcohol use disorder, but they often do not seek help. So how does this all happen? What's the mechanism, and why, when people are drinking alcohol, why does it precipitate suicidal behavior? And really, if we look at both patients with alcohol use disorder and non-alcohol use disorder, so sometimes people will just drink alcohol, and maybe they were not somebody who regularly will commit suicide. But we also see it in people who are daily drinkers, heavy drinkers, at-risk drinkers. It's proposed that really there's a lot of psychological distress. An example of that often is at the root of these is relationship issues. And so if we have marriage issues or other things going on, often people will go out and maybe they're not drinking normally, but they will drink a large amount of alcohol and make a very poor decision. Often the alcohol will cause people to be more aggressive, and it helps, this whole thought about that chance of translating kind of the idea of suicide into an action. And so we often talk about how really talking to a patient about suicide doesn't really precipitate it, but often they'll translate that idea into action if they start drinking. I think it's a really interesting thing if you look at this whole concept of constricted cognition, where patients actually it's almost like tunnel vision. So they get this constricted cognition where their other coping skills when they're drinking alcohol just don't seem to work well. And they will get stuck on one idea or one thought process, and they'll get stuck there and ignore all the other things around them as far as their coping. And so in a way, it's like a tunnel vision in your cognition. If that's, I wasn't supposed to rhyme, but it did. Next. So kind of the setup for alcohol use disorder. And really, I think we could really propose that most substance use disorders, that social isolation is one of those parts of it that helps lead to a suicidal idea or a suicidal attempt. Often when we have alcohol involved, we get patients who have really accelerated their aging. Often these are also patients who smoke. And so they smoke and they drink. And again, as we said earlier, smoking increases your risk of suicide. And so it's really those things that sometimes accelerate their aging. And as we see that, we get poor cognition. We sometimes get this emotional dysregulation where they may lose their temper very easily. They may make very rash decisions. They have difficulty kind of controlling their behaviors. And so I think as you look at just alcohol and smoking together, if we even add other things, and that's why when we see patients with multiple substance use disorders, this becomes more and more of an issue. And so again, poor cognition, I think that's something we always got to think about as patients age and continue to drink. So one of the interesting things about alcohol and suicide is that in a way, they kind of share some neurobiological features, okay? So when they look at patients who have actually committed suicide, many of them have been shown on very close examination of their brains to have impaired serotonin transmission. And we all know that serotonin has a lot to do with how our mood is, and medications are often targeted to increase our serotonin or stop the reuptake of it so that patients have higher serotonin levels. If you look at patients with alcohol use disorders, in their prefrontal brain regions, they actually have found that these patients have decreased binding of serotonin receptors and transporters, and in a way, it causes that same issue. And so the serotonin is potentially the lack of it functioning like it should might be that common pathway between them, because people who have decedents from suicide, even if they don't have alcohol use disorder, have a similar situation when looked closely at their brain. So the brains of patients with alcohol use disorder and suicidal behavior also have a very similar size and shape. And again, if they have atrophy in certain areas, it tends to be very similar. And they've shown that these heavy alcohol users and patients with suicidal behaviors actually have less gray matter. And in various parts of their prefrontal cortex, if you have less gray matter, understand that that's where your decision making comes from. That's where you inhibit some of your more tragic thought processes. So really affecting that prefrontal cortex is going to make a huge difference on the decisions you make or your ability to use your coping skills. So very similar. Patients without alcohol use disorder who commit suicide have very similar appearance of their brains. So let's talk about opioids now and suicide. We'll switch over to opioids. If we look at the rate of lifetime suicide attempts in opioid use disorder, it's amazing that in some studies it's almost 50%. I think that we probably don't talk to our patients enough about how they're feeling and whether or not suicide or suicidal thoughts have crossed their mind. I think that probably all of us have heard patients say, if I had to go through withdrawal again, I'd probably kill myself. I've had many patients say that to me because it is so terrible. And if you look at the opioid use disorder patients and suicide, it's actually doubled in the last year and in the last 10 years. And honestly, I think fentanyl is a huge part of that. The fentanyl withdrawal is an enormous problem. And these are patients that are way sicker than what we ever saw with heroin. But I would say that literally on a every week or two basis, I have somebody say to me, I thought I was going to kill myself. I couldn't take it. It was so terrible. Often they're in jail and they go through withdrawal. They don't get medications, and it can be really horrific. All right. So if you look at opioids, again, remember, in the general population, men were a greater risk for overdose. But when we look at opioids and patients on opioids, it's very clearly female outstrip the men. Okay, they're more often unemployed. They tend to be younger, and again, not a surprise that it's linked with childhood trauma, high ACE scores, often sexual abuse, which we see every day here at the clinic, and again, this family history of suicide. I just had one of my patients with an opioid use disorder. His mother committed suicide about 8 weeks ago. And we have had him in here a lot, and we have these discussions because his risk is certainly higher than the average person by many times. and when he's on buprenorphine, and we'll talk about why buprenorphine helps that, but switching over did seem to help the thoughts that he was getting. And really, if we look at patients who already have depression, as compared to those who don't have depression, in some of the talks I give about opioids, I talk about this a lot, how if we look at patients with depression, for some reason, those patients are much more likely to be prescribed opioids. And in fact, these are often the patients that are on the highest dose of opioids. Why is that? Well, I think a lot of it is because these are patients, when you're depressed, when your mood is down, your pain is worse, and that's how you project it to the person that's seeing you. And so I think it's important to understand that those are patients that are going to be on opioids, and they were already depressed. And then we add on top of that the effect of opioids on mood. Now, the other thing to remember is that patients on the highest doses of opioids are also the patients that are most likely to be on a benzodiazepine. And so we just continue to pile on the problems for this patient. And it's very clear as well that as we increase doses of opioids, we increase risk of overdose and also of suicide. It is very much dose dependent. So acute opioid effects also might contribute to suicide. And I think that, that initial feeling of euphoria and impulsiveness, all these things that can kind of disinhibit a person. We'll see if Dr. Heather's going to walk right through here. Yep, you didn't see her. It's
so
just
fast. Quick like cat.
So also the long-term effects of these medications can affect the mental state. And it's interesting that when we look at opioids, where are you, Heather? You're Heather's trying to find herself, but she's not in the picture. Oh, there she is. We got a real problem with our camera. I liked it better when you weren't there. Okay, so I'll keep talking even though you can't see us. But so one of the interesting things about opioids is they tend to increase sensitivity to the negative emotions. So the things that happen to somebody while they're taking opioids always seem worse. And it causes greater stress, it causes greater pain. And in fact, if you look at what happens when they're on opioids long-term is they're also not sensitive to kind of the natural rewards. So things that would normally make somebody feel better don't. And so it's this constant negative emotion, okay? So how do we keep this patient safe? Well, if we have a concern that somebody's thinking about suicide, they have thoughts, they have a strong family history, and especially during those times, we want to probably change some things and shorten their prescriptions. We don't want patients to be able to stockpile these, and so many of them do. I've had many patients who had stockpiles of both opioids and benzodiazepines and said they could go without a prescription for months, if not a year. And so don't underestimate how many they can have sitting in a drawer at home. You just need to discuss the coping strategies. We need to think, is this a patient that needs to go through counseling? How do we access their family and help them get support? And consider their other risk factors that we've already talked about. So there's their mental health, the other substances they're using. Sometimes it's not just opioids. So I'm going to go in the weeds just for a moment about opioids and just talk for a moment about the Kappa receptor, because this is something we don't talk about a lot. And it's something I think I spent a lot of time trying to ignore. But the Kappa receptor is really important when we look at suicide and we look at depression in people taking opioids. We know the mu receptor, that's the one we talk about all the time. That kind of helps with the pain and the euphoria. But the Kappa receptor, which is an opioid receptor, is probably that mediator of dysphoria and kind of this depressive behavior that people get. And so if an opioid stimulates or activates that Kappa receptor, often these are patients that will have a very poor mood, very dysphoric, and again, can precipitate potentially patients moving on to suicidal thoughts and ideas. And if you look at postmortem brains of people who complete a suicide, and these are patients not on opioids, they actually have a higher expression of Kappa receptors. And so the question would be, are those receptors, because of the endogenous opioids, are they being stimulated? And that's why that patient has struggled with depression and other problems. So there was actually a study done. It's really pretty interesting. They followed we're going to talk a little bit, and this is going to kind of connect some of this Kappa with some of the medications that we use for medication-assisted treatment, okay? And so they followed these patients for 5 years, and they looked at patients who were on buprenorphine, methadone, and naltrexone. And this is a study that lasted a long time, from 2003 until 2017. And it's interesting what they found. It's very interesting that all-cause mortality was actually decreased by all 3 medications, what you would expect. If we're using less opioids, we're probably going to have things could go better. We're going to have less morbidity and mortality. But the one that really stood out in this study is buprenorphine. And it actually most significantly kind of decreased the suicide mortality significantly by 65%. And we'll talk a little bit about why, because I think that's really important for us to understand as people who are dealing with patients taking buprenorphine. So why is it the best choice? And why does it lower all-cause mortality the most? Now, we have to think first off that methadone, when we talk about methadone in general, methadone by itself is associated per prescription with more accidental overdoses than any other of the opioids. And so remember that methadone, being a full agonist, causes respiratory depression. If it's mixed with other medications or drugs, is likely at times to be much more associated with overdose. Remember, buprenorphine with the ceiling effect, we don't see that. We don't see the respiratory depression. And the other interesting part of this is methadone actually is an agonist to the Kappa receptor. So basically, methadone stimulates that Kappa receptor and can still cause some of that dysphoric mood. And very fortunately, buprenorphine does not. Buprenorphine antagonizes that and actually elevates mood. And so there are actually studies going on using buprenorphine as a treatment for very resistant depression. And the interesting part of it is it tends to work relatively quickly. I think often we see our patients back and we think, wow, a week on buprenorphine, they feel so much better. They're not taking an opioid. Is it all that, or is some of that this Kappa receptor antagonism where they're actually have elevated their mood because, yeah, they're not on opioids, but they're also getting some benefit from buprenorphine in a different way. So now we're going to switch over and talk about tobacco. And again, at the beginning of the talk, I talked a little bit about the fact that even just smoking cigarettes increases your risk of suicide. And it's a current smoker is at twice the risk of the general population, a past smoker about 1.5 times. So even if you previously smoked, you have more risk. Somebody who never smoked is general population. And it's interesting is to why this is, and there's not been a lot of studies. I think we could surmise that a lot of times people use these particular substances to calm themselves. They may have anxiety. And remember, anxiety, having a diagnosis of anxiety increases your risk about 4 times the general population. Frequently, we see people who are smoking, and they do it to relax. It's something that they get used to using that helps them cope. And so even when people have previously smoked and stopped, they still have a risk. Now, stimulant use is the last, I'm going to talk real quickly about stimulants and then marijuana, because I think marijuana also is kind of interesting. If you look at stimulant use, remember that at the beginning of the talk, stimulants have a little less of a risk, probably almost half the risk of the things like alcohol and opioids. And actually, if you look at the studies, if you look at people who committed suicide, roughly in the range of 10 to 12% of people roughly have stimulants in their system. But remember, we're not talking about using a stimulant to commit suicide. They actually just had it in there, and it was not actually a toxic effect that caused the death. So when we look at how does it contribute, it's very interesting that there are some studies that have looked at methamphetamine use, suicide, and ACE scores. And if you look at, and the only problem that I see with this particular study is I think as high as an ACE score goes higher, I don't really care what substance you're using. Probably as your ACE score goes higher, you're going to have an increased risk. But there clearly appears to be a dose-response relationship when people are using methamphetamine and they have higher ACE scores. So the higher your ACE score is in a patient that's using in a patient that's using methamphetamine actually increases your risk of attempting or completing a suicide. It's interesting that when they looked at this group, there was a protective effect if people were financially stable, but it was very clear, as we talked about at the beginning of the talk, that psychosis and hallucinations kind of are very much associated with suicide, both when we look at marijuana, we look at mental health issues such as schizophrenia, or we look at things like methamphetamine associated with psychosis. So if you have a patient who is having these kinds of problems and they're not hospitalizable, they're very high risk for suicide. All right. So last but not least, marijuana. And marijuana, this was actually a study that Nora Volkow, a close personal friend of ours. Okay, not really. We ran on a treadmill next to her once. That's about as close as we got to Nora. I hate to even say this, but she ran 2 miles farther than I did. I didn't feel good about that. But they actually did a study back in 2021. Her and Wilson Compton actually was also involved in this, who's been on our ECHO before. And they looked at past suicidal ideation plans and attempts in people, both men and women, who also had major depressive episodes. And if you added on cannabis, you can see in all groups there that cannabis in men actually triples their risk if they're using cannabis during a major depressive episode. It triples their risk. And in women, it actually quadruples their risk of either getting at the idea, planning, or attempting suicide. So very clearly, if we look at this patient group, if we have patients who are developing depression and they try and use marijuana as one of their treatments, generally it's not going to work, and it's going to just make their risk go through the roof. Is it going to go? Okay. If patients also had a major depressive order that was chronic, these patients had a suicidal and plan ideation and plan in 23% of the cases, men only 15%. So just remember that women, much higher risk than men of suicide linked to marijuana. And again, often patients are they're using marijuana because they think it helps their depression and it helps their anxiety. But if they're having any kind of depressive episode, very dangerous. It's interesting too that if you look at, there's a clear dose response curve. So the more somebody smokes marijuana, the higher their risk of suicidal ideation and completion. How about adolescence? And I think this is a place where we all, we see now so much marijuana use in the younger crowd. It's interesting that it probably doesn't change the suicidality. The rates are actually very similar. But one of the big issues is that the potency of marijuana has gone up so much that the rates of psychosis associated with marijuana have gone up. And although there's no great studies yet that have shown that this is increasing the actual completions of suicides in the younger groups, there is the big concern that over time we're going to be seeing much more psychosis associated with high THC levels. And again, anytime there's psychosis, increased risks of attempts and completion. So I think as we see these patients and they're using marijuana, I think a big, very critical part of this is having that conversation with the patient about the risks, especially if they also suffer from depression, anxiety, or any of those other things that may worsen it. Or if they have a family history of psychosis, you want to make sure that you're having this conversation. So this isn't a talk really about treatment. I just have 2 slides left that talk a little bit about just the generalities. And I think it's important to remember that there's no rating scales that are perfect to I'm going to run this person through it, and I'm going to know whether or not they're going to walk out of this building and attempt suicide. It's very difficult to predict. I think we all have had patients that we didn't predict. And again, 83% of these suicides are unexpected, unavoidable, and no one was told. They didn't reach out to anybody. And again, often it's part of that whole social isolation that they're already suffering from. And really the interventions we always have to think about is, do we have to hospitalize somebody for their safety? Always, thinking about medications for opioid use disorder when appropriate, because in a couple different ways that can help their mood, and really treating their psychiatric disorders, getting them in the perfect place and environment. And again, cultural and family engagement can sometimes be helpful, and having people to help you keep an eye on these patients and support them. So again, very general that way. But so just in summary, again, substance use disorders are often playing a role in suicide risk. And even without an SUD, substances can play a role with acute use or psychosis. And so again, what we're doing with our opioid patients, I think, is really helpful. We got to just remember that that just getting patients on buprenorphine can really make a difference in their risk as well. So next and last slide. So I'm happy to entertain any questions if anybody has any thoughts. I hope that wasn't too fast and furious, but it seems like I got in just under the wire.
Okay, I have a question to start. When you were talking about, or when you were looking into the opioid use disorder treatment, the different options for MOUD, did you see anything in there about, because I had a patient this morning, and I don't know if our PA student is on, but
they are.
She, this guy, he's been on his own since he was 14, started drug use really early. He literally has nobody. They're either in prison or dead. He's got this diagnosis of schizophrenia, whether it's actually that or drug use or whatever. What about people who are on the treatment, yet they have none of that? Did you see that? Even treatment, there's only so much it can do because of the hopelessness related to. So part one of the question is, did you see anything on that? And then part two would be the longevity of a substance use disorder, 10 years, 5 years. Does that play into increased risk of suicide?
Yeah, and actually, the first answer is no, I really didn't see much on that. The second answer is I didn't really see any studies that talked about length of time with a substance use disorder. Now, if you look at, length of time, for instance, for an opioid use disorder, length of time is associated with increasing problems, right? Because you're going to get more sleep deprivation because of central sleep apnea, lower testosterone. You're going to have all these other problems that are going to increase your morbidity and mortality. So I do think that in some ways it probably depression follows that,
and just not even the health complications that build up, but the social and situational problems that build up the longer you have it.
But if you think about it, think about patients who have long-term opioids, and because they're not sleeping, they're more depressed, they're anxious, their testosterone are low, so they have more depression. And so the ACE score, which is clearly that's our risk.
And I put the data in there about suicide related to ACE scores, and that's the known data.
Anybody want to unmute and ask any other questions? I'm happy to answer them. And maybe that's a no.
I think another component, just with talking about opioids, not necessarily, I was listening in the car before I got here, with the chronic opioid use is being sure that so much in data, was this an accidental overdose or was this, I thought Haley might have been on, and I don't know if she has any comments on that, but making sure they're
their risk of suicide. So understand that you can double your risk just by being on opioids and be using them correctly as they're prescribed.
Right. In terms of hallucinogens, things I've seen, or just anecdotally, is that it kind of goes back to your psychosis with marijuana, that if you're having, a bad trip from LSD or anything like that, that can increase your risk right there. And so, you'd think that with that, along the lines of the psychosis or, the paranoia or all that.
Yeah, I do think that medical cannabis is no different than cannabis that's bought on the street. If you also are suffering from depression or are having a major depressive episode and you are taking medical cannabis, again, I do think that would change your risk of suicide. And again, it's just like prescribed opioids. They increase your risk of suicide. And so, I do. I think that was a question in the chat. So, but very interesting topic. I know sometimes not the most uplifting, but I do think, again, if I would have one takeaway message, it'd be, boy, don't be afraid to ask patients a little bit, especially when they're early on in their withdrawal and in that first part of their recovery. I think often those are patients that are really in what I always tell them is the rough water, where there's a lot of things. They're typically socially isolated at that moment from their families and friends, and so they do need support.
Their frontal lobe isn't back yet.
Their frontal lobe is not back yet. Penny said, do we know if these rates are the same when they are decriminalized?
That's something that's still being looked at. It's more in the anecdotal stages at that point. It's something that the harm reduction decriminalization groups that we're on are looking at. I mean, you'd think it would be lower because it's the less shame, less guilt, less hopelessness. You know, they're not looking at all of that other stuff that just makes their situation look that much more dire. But I haven't seen like data.
Yeah, neither have I. All right. Well, unless there's more questions, we'll let everybody get back to their workday. Thanks again. It was a fun talk to make, but not so fun to talk about.